doctors. So today we're going to continue our case discussion, focusing mainly on the Mrcp basis 23 consultation station. And today I'm going to talk a bit about the mitral regurgitation. Now remember, in cardiology, mitral regurgitation is a very common case, and there is a high probability that you may come across this case in your short case in the cardiology station as well as in the consultation station. So let's start our presentation. So as usual, we're going to start with the history. So this is a 62-year-old female, and she presents to her GP with 3 months of worsening fatigue and intermittent palpitations. Associated with this is decreased exercise tolerance. She reports being able to carry her groceries from her local grocer to her house, a distance of around 1 kilometer, relatively easily, but is finding she needs to take a few breaks on the way, which concerns her. Now remember, often the initial symptoms of left-sided valvular disease such as mitral regurgitation may be non-specific. So in this case, the initial symptom was fatigue. So here the long-standing nature of the patient's symptoms show that this has been a chronic issue, and it is likely that there has been a period of being asymptomatic prior to developing the symptoms. Remember that the chronicity of symptoms has diagnostic significance, and primary degenerative causes of mitral regurgitation become more likely than ischemic causes. We're going to discuss about the primary and secondary causes later. The history of palpitation here should raise suspicion of either tachycardia or irregular heart rhythm such as atrial fibrillation. So compared to the patient baseline, there is a degree of compromised left ventricular output as there is a decreased exercise tolerance. Most people, they are able to walk on the flat at a leisurely pace for 1 kilometer, even if they had sedentary lifestyle. So in this patient, needing to take breaks due to dyspnea should raise concern in the treating doctors, and a detailed cardiovascular assessment is required. On further questioning, she also reveals she has noticed some ankle swelling over the past couple of weeks and woke up last night short of breath. Now remember, we all know that peripheral edema is actually a sign of right heart failure. The other signs of right heart failure includes pulsatile liver, congestive hepatomegaly, raised GVP. There are many causes of right heart failure, but in this case it will be due to left heart failure from mitral regurgitation. Now what the patient describing here, that she woke up last night short of breath, is PND, and this is a sign of severe left heart failure, and patient may have had orthopnea in lead up to this. So always complete your cardiovascular system review if a patient chief complaint is cardiovascular nature. Okay, let's move on to our history. So otherwise, she has no chest pain, no pre-syncopal episode or syncope. She has been recently well, and her past medical history is only significant for hypertension, which is well controlled on her usual Remipryl. So at this stage of assessing the patient without an echo, the only thing that is apparent is that the patient is in heart failure. Now, knowing that the patient has been previously well with no preceding infective symptoms, this helps in that infective inflammatory etiologies like viral-induced cardiomyopathies and infective endocarditis becomes less likely. Uncontrolled hypertension is a risk factor for heart failure with preserved ejection fraction, and had the patient blood pressure been high untreated, may have been a confounding factor in her presentation. In terms of family history, the patient mother died from a stroke, age 83. Now, in the elderly patient with cardiovascular history, it is important to take a good drug history. Recently commenced drugs such as NSAID, calcium channel blockers, antidepressants, phosphodiesterase E5 inhibitors, and chemotherapy agents have the ability to trip the patient over to heart failure. And obviously, we want to know about the family history also. So this is all about the history. Now let's move on to the examination. So on examination, from the end of the bed, the patient appears well. She has slim body habitus. She does not appear dyspneic but displays mildly increased work of breathing with mild sternocleidomastoid use. Heart rate is 123 and is irregular. So again, the initial assessment of the patient should be observation. One can quickly assess the urgency of the situation by how unwell a patient looks. There is a mildly increased work of breathing. The history of biventricular failure suggests that there will be degree of pulmonary edema on examination. Respiratory compromise can be assessed in work of breathing, increased use of sternocleidomastoid muscles, intercostal and subcostal recession, and triponding are all signs of increased work of breathing. In adults, a tracheal tug is suggestive of severe increased work of breathing. Now, irregular pulse is most suggestive of atrial fibrillation, but without a confirmatory ECG, an irregular pulse may be misconstructed for a regularly irregular pulse. Irregular pulse could also mean a variety of other rhythms like frequent premature ventricular complexes, focal or multifocal atrial tachycardia, sinus node dysfunction, or atrial flutter with variable block. The patient is tachycardic but does not have a blood pressure compromise. The blood pressure is 160 by 80 mmHg. So you can take the blood pressure. If the apparatus is available, you can ask the examiner, I want to check the blood pressure of the patient. Respiratory rate is 26 and saturation are 88% on air, and she is afebrile. The JVP is 5 centimeter. Obviously not going to check the saturation, but maybe you can mention in your presentation. So the JVP is 5 centimeter. JVP of 5 centimeter with peripheral edema to knee is a sign of right heart failure. Auscultation of the heart reveals a harsh pansystolic murmur, loudest in the apex and radiating to the axillae. The murmur is accentuated when she is in deep expiration, gripping her hands, and in the left lateral decubitus position. The mitral valve is best heard at the apex with the bell of the stethoscope, and mitral regurgitation classically radiates to the axillae. Severe regurgitation valvular pathology may actually radiate throughout the precordium. Now remember, there are numerous dynamic maneuvers that can accentuate left side and right side murmurs. Left-sided regurgitant murmurs can be accentuated by exercises that increase the afterload of the heart, such as isometric hand grip, transient arterial occlusion by placing blood pressure cuff on both arms and then inflating to 20 to 40 mmHg. Laying the patient in the left lateral decubitus position places the apex of the heart closer to the surface in the thoracic cavity, so make it easier to hear the murmur. In comparison to this, the aortic murmur, they can be accentuated by having the patient lean forward. Left-sided murmurs are always heard better during expiration, where there is decreased intrathoracic pressure and increased venous return. so promoting further turbulent flow through walls due to increased volume being run through the heart. Let's move on to our examination. So the apex beat is displaced to the mid-axillary line of the sixth intercostal space. Auscultation of the lung reveals bibasal crepitation and dullness to percussion in the basis, and there was peripheral edema to the knee on examination. So a displaced apex beat is indicative of cardiology of any cause. In the overall picture here, there has been some chronic remodeling of the heart to compensate for the valvular pathology. So if apex beat is displayed, it can be further characterized as a pressure-loaded or volume-loaded apex beat. Bibasal crepitations are more often than not due to the hypervolumic states such as pulmonary edema, and it is also possible to have bibasal pneumonia, but this is uncommon. Associated with bibasal crepitations are dullness to percussion, which is suggestive of fluid in the basis of the lung, that is bibasal pleural effusion. And as I mentioned before, peripheral edema suggests that there is a degree of biventricular failure in this patient. The patient was referred to the emergency department after review at a GP. So obviously the patient is showing some signs of heart failure, so it's better to refer the patient to the emergency department. So that's all about the examination, and I have highlighted all the positive findings in red, so you must be aware of what findings to be looked for. I'll give you a quick tip. Suppose if you are in a cardiology station and once you feel the pulse and you think the pulse is irregular, you're thinking of atrial fibrillation, most likely it will be mitral valve pathology, mitral stenosis or mitral regurgitation. Okay, let's move on to the investigations. So first of all, we'll like to do the ECG, and we'll be expecting to see some left axis deviation. So here we see left axis deviation, heart rate of 103 with no discernible P waves and an irregular RR interval, and there is also marked left ventricular hypertrophy. So the mean electrical axis of the heart has shifted to the left, indicating left-sided predominance of myocardium, which may indicate a degree of left ventricular hypertrophy. And irregular RR interval, where this is the definition of atrial fibrillation on ECG. And there may also be an wandering isoelectric line, or if there is rapid ventricular response, rate-related ischemic changes such as T-wave inversion or ST segment depression elevation, they also can be seen. Chest X-ray revealed an increased cardiothoracic ratio of 0.6 with bilateral blunting of costodiaphragmatic angles and upper lobe diversion of blood vessels. We're going to do the chest X-ray. Sometimes the examiner may ask what the findings you will be expecting in the chest X-ray, so you must be aware of it. So the cutoff for cardiomegaly on chest X-ray is a cardiothoracic ratio of more than 0.5, and the other findings which we see in this chest X-ray are consistent with the pulmonary edema. Sometimes there may be increased interstitial markings and curly B lines, which may be evident in the chest X-ray. Full blood count and urea, electrolytes and creatinine are normal. Transthoracic echo was performed as an inpatient, which revealed severe mitral regurgitation secondary to a flail segment of the posterior valve leaflet. The mitral valve leaflet was 6 mm in width, and there were no vegetation seen. So the key investigation here would be an echo. It is the best non-invasive means of assessing the valvular pathology to show the etiology behind the mitral regurgitation, quantify the severity of mitral regurgitation, and see the associated changes within the left ventricle and left atrium, and also assess for the sequelae of the primary valvular pathology such as raised pulmonary artery pressure. So remember that the mitral valve apparatus is actually a complex and dynamic three-dimensional structure with multiple components, and there is a large anterior leaflet and a smaller posterior leaflets. And these leaflets have chordae tendineae that are themselves attached to papillary muscles, which anchor the leaflets to the left ventricle wall to prevent prolapse into the left atrium during systole. So mitral regurgitation occurs when the mitral wall fails to close during systole, so allowing regurgitation from the left ventricle back into the left atrium. Now, this can occur from pathology of the mitral valve apparatus or from distortion of the left ventricular geometry, preventing the leaflet apposition during systole. So, primary mitral regurgitation is primarily a valvular pathology. The causes include mitral valve prolapse, papillary muscle rupture, chordae tendineae rupture, leaflet perforation, that is in infective endocarditis. In comparison to this, secondary mitral regurgitation, which primarily is actually a myocardial pathology, is also known as functional regurgitation. The causes include regional wall motion abnormalities from previous infarct, dilated cardiomyopathy, myocarditis, or left ventricular dysfunction of any cause. Mitral valve prolapse most commonly occurs from myxomatous degeneration, where the fibrous layer of the wall thins, so allowing the mucoid material to accumulate. And over time, it elongates and thins the chordae tendineae, producing them to rupture. And it also causes the wall leaflets to become floppier and impairing the position of leaflets in systole. Briefly about other rare causes of mitral valve prolapse are connective tissue disorders such as Marfan syndromes, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, osteogenesis imperfecta, and SLE. So, although this case is mitral regurgitation, but if it is a mitral valve prolapse, the classical finding of mitral valve prolapse is a crisp mid-systolic click with a late systolic murmur. Okay, so the vena contracta width, so we discussing the echocardiography findings, was 0.73 centimeter. The regurgitation fraction was 53, and the ERO was 0.45 centimeter square. And there was also mild left ventricular enlargement and moderate left ventricular hypertrophy with left ventricular ejection fraction of 40%. The estimated pulmonary artery pressure was 35 mmHg. Now remember that quantifying the mitral regurgitation, it has a prognostic significance. So when comparing two patients who are asymptomatic, the patient with severe mitral regurgitation will have much lower life expectancy than the patient with mild mitral regurgitation. This is because the patient with severe mitral regurgitation will have less cardiovascular reserves and will be more prone to developing heart failure. So the current guidelines suggest that severe mitral regurgitation is indicated by vena contracta. It's actually other name for regurgitant jet, maximal width of more than 0.7 centimeter. Regurgitant fraction of more than 50% and effective regurgitant orifice of more than 0.4 centimeter square. So these are the parameters which in the echocardiography which will give us a clue whether it is a mild mitral regurgitation or it's a severe mitral regurgitation, even though the patient is asymptomatic. So mitral regurgitation actually results in blood regurgitating back to the left atrium, so it results in increased left atrial and diastolic volume, So over time, the volumetric overload of the left atrium causes it to dilate, and the dilatation of the left atrium actually results in progressive fibrous remodeling of the left atrium as well, so resulting in increased risk of developing atrial fibrillation and other atrial arrhythmias. You may also see ECG signs of left atrial enlargement in patients with chronic mitral regurgitation and prolongation of the P wave duration more than 120 millisecond, or it is called P mitral, which is when the P wave has a bifid morphology in lead 2. This findings may be seen in V1 to V6. So here the patient, the left ventricular ejection fraction is 40%. So it is clear from decreased left ventricular ejection fraction that the left ventricle is unable to pump out a normal volume of blood into the system despite the compensatory eccentric hypertrophy. So the inability of the left ventricle to pump out all of its received venous return has resulted in backlog into the pulmonary arterial system and systemic venous system. And this decomposition is actually obvious upon history and examination, and the patient has symptoms and signs of biventricular left ventricle failure. So left ventricular ejection fraction is classified as when we talk about 50 to 70% is normal, 40 to 54% is mildly reduced, 35 to 39% is moderately reduced, and less than 35% severely reduced. So in this patient, the transesophageal echocardiography was also performed, and pre and post-operatively for perioperative planning and to assess the valve post mitral valve repairs. Transesophageal echocardiography provides a three-dimensional view of the valvular apparatus as opposed to the two-dimensional view obtained in its corresponding transthoracic study. So this makes it an invaluable perioperative investigation and helps in planning out for surgery. So this is all about the investigations, and now we move on to the management. So management, I have divided the management into supportive management, surgical management, and the follow-up management. So this patient is actually, patient need to be admitted under the cardiology team in the coronary care unit initially. If they are presenting with pulmonary edema, we provide supportive therapy and we aim for euvolemia. So this patient is dyspneic and patient is also hypoxic. So supplemental oxygen via nasal prongs should be administered to maintain saturation above 92%. Then obtain IV access. Administer IV furosemide to offload the fluid. Further supportive therapy for this will be commencement of a 1.5 liter fluid restriction, a strict fluid balance chart, and daily weights to monitor diuresis and fluid loss. So in this patient supplemental oxygen should be given to correct hypoxia as a first-line measure. Failing nasal prong cannula, you can use a Hudson mask, or if needed, a non-rebreather reservoir mask. So in cases where the saturation is still less than 92% despite a non-rebreather mask, CPAP, which is continuous positive airway pressure, can be given. It has been shown to have a mortality benefit and reduce the need for intubation. However, remember, if the patient is hypotensive, CPAP should not be given as it can further worsen the hypotension. Because CPAP increases the intrathoracic pressure, which lessens the natural pressure gradient that allows for venous return. And obviously, the decreased venous return reduces the preload of the heart. And if you remember, according to the Frank-Sterling law, it causes decreased stroke volume and cardiac output. So IV furosemide is actually needed to correct the hypervolemic state in acute pulmonary edema. For patients who are furosemide naive, a start dose of 40 to 80 mg may be administered. For patients who are already on furosemide in the community, a higher doses may be needed to achieve adequate diuresis. So a fluid restriction is important to prevent hypovolemia. A strict fluid balance chart will assess the volume of diuresis, and daily weights are the best measure of fluid loss on a day-to-day basis. So this is all about the supportive management. Still we have few points left. So manage the rapid ventricular response of atrial fibrillation with oral metoprolol. Patient with atrial fibrillation should have their charge VAS2 score evaluated and be appropriately anticoagulated. So the patient has a rapid rate. In this state, the metoprolol is a good means of attaining rate control. Digoxin can be considered, but is not as effective as metoprolol for rate control. Therapeutic enoxaparin is the choice of anticoagulation in patients with atrial fibrillation who are awaiting a procedure. This is because the enoxaparin action is relatively short-lived when compared to warfarin or direct oral anticoagulants and can be withheld 12 to 24 hours prior to procedure with minimal increased bleeding risk. So in comparison to this, the warfarin will require INR correction with vitamin K or prothrombyl complex concentrate, and direct oral anticoagulants, they requires a minimum of 48 hours to be renally excreted. Of the direct oral anticoagulants, only dabigatran has a reversal agent. For those undergoing procedures, however, low molecular weight heparin such as enoxaparin may be used for its shorter half-life. So we have to do the Charles-West score for atrial fibrillation and must consider for the oral anticoagulant. And now, according to the NICE guidelines, the direct oral anticoagulants, because if there is a valve pathology, they are not actually the first line. So still, like in this patient, we like to use the low molecular weight heparin like enoxaparin. And obviously it will be discussed, and if we want to do the surgery early, then maybe we can continue with enoxaparin, and if we for the long term we have to use the vitamin K antagonists like warfarin. Now, the only definitive management for mitral valve regurgitation surgery and a referral to a cardiothoracic team will be made for consideration of the type of surgery. Remember, as a general rule, surgical treatment only really has a role in a patient with primary mitral regurgitation, and surgical intervention has only a limited role in secondary mitral regurgitation, as the problem is not with the valve itself, rather the myocardium. Thus, fixing the valvular pathology will not carry any significant prognostic benefit. Furthermore, surgical intervention in primary mitral regurgitation is aimed at mimicking the native valve as much as possible. So the mitral valve repair is preferred over mitral valve replacement, and mitral valve replacement, and if mitral valve replacement is needed, caudal preservation is preferred over removal of the chorda. So this patient actually requires surgical intervention as she has chronic primary mitral regurgitation with features of decompensation. So indications for mitral valve surgery in primary mitral regurgitation are chronic severe primary mitral regurgitation with left ventricular ejection fraction more than 30%, severe left ventricular systolic dysfunction with left ventricular ejection fraction less than 30%, acute mitral regurgitation from either papillary muscle rupture in ST elevation MI or infective endocarditis. So these are the symptomatic patients. In asymptomatic patients, severe mitral regurgitation with preserved left ventricular function, and if there is a new onset of either AF or pulmonary hypertension, if there is a high likelihood of durable repair lower surgical risk and flared leaflet, and left ventricle and systolic dimension more than 40 mm. Severe mitral regurgitation with severe left ventricle dysfunction refractory to medical therapy and high likelihood of durable repair and low comorbidities. So further benefits to mitral valve repair compared to mitral valve replacement are that patient need not have lifelong anticoagulation with warfarin. The repair lasts longer than replacement, and there is an overall mortality benefit with mitral valve repair. With regard to mitral valve replacement, mechanical prostheses are preferred over the bioprosthetic valves for their better durability, and this patient requires lifelong anticoagulation with warfarin, aiming for an INR of 2.5 to 3.5. So post-op care, the patient need to be monitored in the HDU ICU with cardiac monitoring for the first few days post-operatively. Mitral valve surgery requires median sternotomy and cardiopulmonary bypass, and patients are prone to many complications in the immediate post-op period. So the major complications including because of the wound, there may be superficial wound infection, deep sternal wound infection, wound dehiscence, sternal instability or massive sternal hemorrhage. In relation to the valve, complications can include prosthetic endocarditis, repair failure, prosthetic thrombosis, perivalvular leak. In terms of cardiac, we may have a dysrhythmias or tamponade. They can be stroke. They can be brachial plexus injury from sternal wound retraction. So, late complications of mitral valve replacement are paravalvular leak, prosthetic endocarditis, and thrombosis. And these are actually horrible complications. So in the follow-up, post mitral valve repair, patient requires follow-up in a cardiothoracic clinic, initially 6 weeks post-repair to ensure adequate wound healing and no late complication of the valve repair occur. From there, patient can be reviewed 6 to 12 monthly until discharge from clinic. Parallel to this, patient should be followed up in cardiology clinic with serial echocardiogram to assess the resolution of hypertrophy and to manage the atrial fibrillation. So concomitant cardiology follow-up is important. The patient will require serial echo to assess for resolution of eccentric left ventricular hypertrophy, any residual left ventricular dysfunction, improvement in left ventricular atrial volume index, and pulmonary hypertension. So additionally, if the patient has had significant atrial fibrillation or has received a prosthetic valve, they will need cardiology input to optimize their treatment. So, dear doctors, that is all about the mitral regurgitation. I've tried to cover all the relevant points and the questions which can be asked in this session. So, hopefully it will help you, and I'll see you in my next presentation. Thank you very much.